So today I'll be presenting an update on a few otology topics. The first topic that I will discuss or share with you guys is the Meniere's disease clinical practice guidelines that were recently published. We'll also talk about vestibular migraine, which can often overlap or mimic Meniere's disease. I'll talk about briefly cochlear implant for single-sided deafness, as well as updates in bone conduction hearing implants. So as you're all, I'm sure, aware, Meniere's disease is a chronic progressive disease of episodic vertigo, fluctuating hearing loss, tinnitus that patients often describe as buzzing, humming, or a seashell type sound in one ear, with an additional symptom of aural fullness. This is a rare disorder. It affects between 3.5 and 500 people per 100,000. Typically presenting in patients between the ages of 40 and 60 years old. Women are affected more often than men, almost 2 to 1. We don't know what causes Meniere's disease. There's a number of hypotheses, and I have those listed here. It could be one of these, it could be multifactorial or a combination of these. But whatever the cause, there's an overaccumulation of endolymph in the endolymphatic space, fluid in the endolymphatic space. This can be secondary to excessive production or inadequate absorption of the fluid. It results in a dilation of the endolymphatic space. On this slide, I have 4 images. The top 2 images depict a normal cochlea. Then the bottom images are the ear of a patient with Meniere's disease. What's key to observe in these images, especially for residents or people who may be taking board or in-service exams, is the dilation of the scala media that we see in the patient with Meniere's disease. So in the top normal image, the scala media is relatively small compared to the scala vestibuli, and it's separated by Reissner's membrane, which is a straight kind of linear membrane. In the Meniere's disease ear, the scala media or the endolymphatic space is dilated, and there's bowing of Reissner's membrane. So that's the characteristic finding. Again, this is a chronic disease. It's progressive. Early on, it fluctuates frequently. There's frequent exacerbations of the vertigo spells. Over time, however, the vertigo becomes less frequent or resolves altogether. The hearing loss can continue to progress, or it may stabilize. In about 10 to 25% of cases, both ears are affected. Typically, when both ears are affected, this occurs within the first 7.5 years or so. Our approach to treating patients with Meniere's disease is really to try to reduce the frequency and the severity of vertigo attacks. So this April, the Academy published clinical practice guidelines for Meniere's disease. This is the first guideline published for this problem. For those of you who are perhaps new to otolaryngology, clinical practice guidelines are basically do's and don'ts in the management of a particular disorder. In clinical practice guidelines, the guidelines are presented in what's called key action statements. And these key action statements present either a strong recommendation, a recommendation, or an option. And so for the strong recommendations, the obligation for the practitioner is to follow this obligation unless you have a really clear, compelling reason to do otherwise. In strong recommendations, these are based on grade A or grade B evidence. And this evidence shows clear benefit of an intervention over a harm. For recommendation, these are based on grades B and C evidence. The obligation is that we should follow these recommendations, but stay up to date with the literature and be aware of your patient preferences. For a recommendation, the benefit exceeds the harm, but the evidence may not be as clear or as strong as for a strong recommendation. And then the last type of key action statement is an option, meaning you can do this if you want or if it's appropriate, or if it's something the patient requests. The option recommendation is based on grade D evidence, which they call suspect evidence. And so this is observational studies, or this is case reports, It can also be based on grades A, B, or C literature where there's no clear advantage shown. And then this slide just quickly reviews the grades of evidence. So in this spring's published guideline, the Academy presents 17 key action statements. 11 of those action statements are recommendations, so those are the do's. 13 are recommendations against, the don'ts, and then 3 are options. So we'll briefly go through these and try to get through them within the next half hour. The first key action statement is a recommendation, and they recommend that you make the diagnosis. That's obvious. But with this, they give diagnostic criteria for definite and probable Meniere's disease. The diagnostic criteria for Meniere's disease were first established by the Academy in 1995. And then recently, these criteria were revised by the Béarnais Society and approved by our Equilibrium Committee in 2016. To make the diagnosis of definite Meniere's disease, a patient should have at least 2 episodes of spontaneous vertigo lasting anywhere between 20 minutes and 12 hours, half a day. They must have an audio that shows the characteristic low to mid-frequency sensorineural hearing loss occurring around the time of the dizzy spell. And they should have fluctuating symptoms of hearing loss, fullness, or tinnitus in the affected ear. The difference between a definite diagnosis of Meniere's disease and a probable diagnosis of Meniere's disease is the audiogram. And then the second difference is minor, and that's for probable, the dizzy spells can last more than 12 hours, up to 24. The second key action statement is also a recommendation, and they recommend that we determine whether or not the patient also has vestibular migraine. So patients can have vestibular migraines that are presenting similar to Meniere's disease, or they may have concomitant vestibular migraines. And so it's important to establish the diagnosis of vestibular migraine if it's present so that you can initiate appropriate treatment. We'll talk a bit more about vestibular migraine after reviewing the action statements. The third recommendation is the only strong recommendation that the committee makes, and that's to obtain an audiogram. The reason that this is so important is that it differentiates definite Meniere's disease from probable Meniere's disease. Obtaining an audiogram is also important because it allows you to initiate or get the patient set up for hearing rehabilitation, whether that be with a hearing aid or if the hearing loss is severe enough, a cochlear implant. If you obtain an audiogram and you find that the clarity, the word recognition is much worse than you expect based on their hearing thresholds, then you should really consider the possibility of retrocochlear pathology and consider getting an MRI. The fourth key action statement provides the option for an MRI. So it's not recommended for or against, but you have the option. The reason that it's not a recommendation is that really the number needed to treat. And so you have to get 600 MRIs of patients with dizziness and non-sudden hearing loss in one ear to make the diagnosis or identify a vestibular schwannoma on MRI imaging. The downsides are that we're exposing the patient to unnecessary radiation, the stress and discomfort of an MRI. We have claustrophobic patients. It can be costly depending on the patient's insurance, and it can potentially delay the diagnosis and treatment of Meniere's disease. Some key features that may make you more concerned for retrocochlear pathology or a tumor would be hearing loss that's not fluctuating, hearing loss that's in mid to high frequencies, patients with chronic imbalance instead of episodic vertigo. And then the last thing to note is if you're not certain, you don't have to race to get an MRI. Oftentimes when we find a tumor on MRI imaging, we observe for a period of time before intervening anyways. Certain MRIs, if done correctly and read by an expert radiologist, can make a diagnosis of Meniere's disease, or at least observe dilation of the endolymphatic space on imaging. But this is not seen in all patients. The imaging study has to be done in times just right. And again, you need an expert radiologist. So don't get an MRI with the plans of making a diagnosis. The fifth key action statement is a recommendation against, and so the authors recommend against obtaining routine vestibular testing. So this is VNG and ECOG. Patients with Meniere's disease may have normal vestibular testing, and so getting the testing and finding a normal result can delay a diagnosis, can delay treatment, and also can be disconcerting to the patient. The patients may feel like they are doing horribly, and they may be doing functionally horribly or disabled. And when they find that, or when we find that VNG and ECOG are normal, the patient's not very comfortable with that finding and sometimes question your diagnosis with lack of evidence. Additionally, ECOG can demonstrate increased SPAP ratio, which is the finding for Meniere's, but this also can be seen in third window disorders such as superior canal dehiscence. Lastly, ECOG protocols are not standardized from one institution to the next, and all institutions don't have access to the same software. And so certain software for ECOG can be more sensitive than others. And so one test may reveal an abnormality, but tests on substandard software may not. You should, however, obtain vestibular testing prior to administering ablative therapies. And so if you're considering IT, gentamicin, or doing a labyrinthectomy, you want to make sure that you're treating the right or the correct ear to avoid creating a bilateral vestibular hypofunction in your patient. Additionally, you can utilize vestibular testing after treatment to assess the efficacy of your intervention. Key action statements 6 and 8 are recommendations to educate your patient. And so what's convenient about all of the clinical practice guidelines is that they come with FAQs for the patients. And these FAQs can be presented as handouts to the patient to answer many questions that they have and give them something in writing to take home after you have a discussion with them about what to expect and what to do. And so share with your patient what to expect going forward with the natural history of Meniere's disease, how to control symptoms, avoiding triggers, initiating a low salt diet, and also outline the treatment options or the treatment ladder that we use in our approach to Meniere's disease. The seventh statement is a recommendation to treat the acute attacks. And so when the patient has these dizzy spells, you want them to have something at home to minimize the duration and the severity of these spells. There's 3 classes of medications that we utilize to treat these acute attacks. The first is antihistamines, and meclizine is the most commonly prescribed medication in this class. It's really important to educate your patients to only take this medication when they're having a dizzy spell, when they're having vertigo, excuse me. The downside to meclizine, unfortunately, is that it makes patients really drowsy. And so patients will typically say they take their meclizine and they fall asleep for hours, and they might not need that much of a hit. I like to let some of my patients have the option for a benzodiazepine. There's 3 listed here. Lorazepam is a nice choice of medication because it has the fastest onset of action of the 3 listed, and it's not as sedating as the meclizine. And then the last class are the anticholinergics. These aren't prescribed commonly in my experience or my awareness. One potential benefit to the scopolamine is that it's transdermal, and so if a patient is having severe nausea and vomiting and can't keep anything down, that's a reasonable option. The 9th statement is an option, which is interesting because I think in many of our practice, diuretics are kind of the mainstay in our management of patients with Meniere's disease. But based on the lack of quality evidence, the panel guideline makes or provides or suggests, the option to offer a diuretic or betahistine. The goal in this maintenance therapy is to reduce the frequency or severity of the patient's dizzy spells. The way that the diuretics work is that they reduce the endolymphatic fluid volume that we know is increased with a distended space. The most commonly prescribed class of diuretics are the thiazide diuretics, specifically hydrochlorothiazide. You can prescribe hydrochlorothiazide alone, or you can do it as a combination medication with triamterene, and so we call that diazide or Maxide. The advantage to prescribing diazide as compared to hydrochlorothiazide alone is that the triamterene is a potassium-sparing diuretic. So when you prescribe just hydrochlorothiazide, patients are at risk for hypokalemia, and you may need to additionally prescribe a potassium supplement, which often comes in a big horse pill that's hard to swallow, or ask the patient to eat a banana. And so the diazide is a nice workaround to that. Other options for diuretics are the spironolactone and Diamox. Betahistine is a second option of pharmacologic treatment for Meniere's disease. Betahistine is an H3 antagonist or a weak H1 agonist. The mechanism of action is not fully understood, but it's thought that this medication causes vasodilation and increased absorption of endolymphatic fluid. This medication is not FDA approved, and so it can, depending on where you are or where the patient is, be difficult for patients to get their hands on. I know patients have gone to Canada in the past. There are compounding pharmacies in this country that can provide this medication as well. The 10th statement is a recommendation against, and so the guideline recommends against prescribing a Meniett device. A Meniett device is a small device in which you place a probe into the ear, and through that probe, small pulsations of pressure, 25 centimeters or water, are inserted into the ear canal. A tympanostomy tube needs to be in place for this to be effective. And the way that this device is thought to work is that by applying that pressure to the ear canal and middle ear by way of the tympanostomy tube, it facilitates absorption of the endolymph. The reason this is a do not is that there are systematic reviews showing ineffectiveness of this device. Additionally, placing a tympanostomy tube is not without risk. It's a low risk procedure. We do it every day, but it's not without risk. And so there's a risk of perforation, there's a risk of making the patient's hearing worse, and there's a risk of chronic otorrhea. It is worth noting that some of the panel or guidelines members did not agree with this recommendation against, and so it's your choice. If it's something that's in your practice, it's okay to continue doing this. It's not part of my practice, but I don't think that the evidence of harm is strong, and I don't think that some of the panel did either. The 11th statement is the option to treat with intratympanic steroids. And so treating with intratympanic steroids is to address the vertigo, the dizzy spells. This is not necessarily to treat hearing loss. The reason that this is an option is that there is limited data, and there's heterogeneity of the data that is available, both with the reporting of outcomes as well as treatment protocols. It has been demonstrated to show some improvement of vertigo symptoms, but is not as effective as IT gentamicin. And then again, anytime we put a hole in the eardrum, there's a risk of tympanic membrane perforation or otitis media. Statement 12, we are recommended to offer IT, intratympanic gentamicin, for refractory disease. And so this is for the patients who still have frequent episodes of vertigo, despite a low salt diet, treatment with a diuretic and or betahistine, potentially having failed treatment with intratympanic steroids. Gentamicin is a medication that is more toxic to our balance system than it is to our hearing system. So the vestibular toxicity is greater than the cochlear toxicity. It results in a chemical ablation or chemical labyrinthectomy, ablation of the vestibular function of one ear. You should make sure that you're treating the right ear. So obtain a VNG to localize the disease so that we're not creating a patient with bilateral vestibular hypofunction, which is debilitating. The way to perform these injections, the guidelines recommend weekly or as needed injections as compared to a daily injection or infusion in an effort to reduce the risk of hearing loss. They don't recommend a specific dosing protocol, but they do outline a systematic review in which 34 studies and over 1,200 patients were reviewed with who were injected with IT gentamicin at doses between 10 and 80 milligrams per ml and had almost a 90% control of vertigo symptoms. It's worth noting that the higher dose of gentamicin resulted in a greater incidence of hearing loss, 91% in the patients with 40 mg per ml dosing, but under 30% in those patients dosed at 30 milligrams per ml or less. The next statement is also a recommendation to provide or offer a labyrinthectomy if the patient remains symptomatic despite conservative therapy. And that conservative therapy can include the IT gentamicin on the previous slide. This is recommended for patients who have non-usable hearing, which the authors define as Class D hearing. And so any hearing threshold, but with speech discrimination less than 50%. The way that this works to control a patient's or eliminate a patient's vertigo symptoms is that you're converting a dynamic, basically mouth-firing engine or inner ear to a static, non-functioning ear. And so we're eliminating the aberrant input from the Meniere's disease ear, and this allows the brain to compensate over time. Labyrinthectomy has been shown to be over 95% effective. The next two therapies are included in the labyrinthectomy statement, but aren't labyrinthectomies and they aren't ablative treatments, but they have been used in the treatment of persistent vertigo in patients with Meniere's disease. The first is vestibular nerve section, and so this requires a craniotomy, and it comes with risks, so a risk of CSF leak, a risk of cranial nerve 7 palsy, a risk of hearing loss because of the intimate association of the vestibular and cochlear nerve fibers. If you incompletely sever the superior vestibular nerve, there's a risk of residual symptoms. But nonetheless, the authors say that you may offer this in select cases. And so this is for the patients who have residual hearing. And then the last surgery that's mentioned is endolymphatic sac surgery, but the authors specifically state that they aren't making any recommendations for or against this procedure. Statement 14 comes in two parts. Part A states that we should offer vestibular physical therapy or rehab to our patients who have chronic imbalance. Part B specifies don't do it for the acute attacks. Statement 15, help them hear, and so counsel the patients and refer them for hearing rehabilitation. And so that can be something as simple as a personal sound amplification device, hearing aid, traditional hearing aid, or cross by cross, depending on the severity of hearing loss in the affected ear and the clarity on that side. And then lastly, cochlear implant, which is again recently approved for single-sided deafness. But some patients, some Meniere's patients may have both ears affected and may be a candidate in both ears. And then lastly, document. And so it's common sense, but document how the patient responds to the treatments that you've provided. Are they getting better, worse, staying the same with regards to the vertigo, the tinnitus, and the hearing loss? But sometimes it's not Meniere's disease, and so this is where we'll make our transition to vestibular migraines. Migraines are relatively common. The prevalence of migraine in the US is 15% among Americans, 20% in females, and about half of that in males. About 10% of migraines are vestibular migraines, and the prevalence of vestibular migraine in the general population is almost 3%. On the other hand, the prevalence of migraines of Meniere's disease is less than 0.5%. But it's important to be aware that as many as half of patients with Meniere's disease can have vestibular migraine. So when you're evaluating a patient for Meniere's disease, you should keep vestibular migraine in the back of your mind, or really in the forefront of your mind, because it's a more likely diagnosis, but the two can occur together. Vestibular migraine is becoming an increasingly recognized etiology of vertigo, but even with that, it's often underdiagnosed or even mismanaged. And so when you have your Meniere's patient, consider whether or not they have a concomitant diagnosis of vestibular migraine, and just know that it's okay to treat them for both if they have both. So the Béarnais Society has created diagnostic criteria for vestibular migraine. To make a diagnosis of definite vestibular migraine, a patient should have had at least 5 episodes of vestibular symptoms, and these vestibular symptoms can be spontaneous vertigo, motion or visually induced vertigo, lasting 5 minutes to up to 3 days. They should have a current or prior history of migraine headaches as defined by the International Classification of Headache Disorders. And they should have at least 1 or more migraine features with half of their disease spells. And so those migraine features, it can be a headache, it can be a symptom of photo or phonophobia, or simply visual aura. And then lastly, the symptoms can't be better accounted for by another vestibular or headache disorder. The next category of diagnosis is probable vestibular migraine. And so with this, the patients have had at least 5 episodes of vestibular symptoms, and then they either have a history of migraine headaches, or they have migraine features with at least half of their vestibular spells. Oops. The treatment of migraine disorders, some ENT physicians and neurologists will elect to treat these, and others will elect to refer these to a neurologist. A conservative way to treat these patients, if you don't feel comfortable prescribing medications, or if you'd like to get started treating this medication until the patient is able to schedule an appointment with the neurologist, or diet and lifestyle modifications. And so there's a number of handouts that are available on the internet for the treatment of migraines. Some of these are just common knowledge: avoiding caffeine, avoiding chocolate, smoked meats, red wine, those sorts of things. We know that being stressed, tired, fatigued can increase the frequency of migraine symptoms. And so making the patient aware of those and encouraging them to make modifications as they're able to until they can see neurology. Medications used to treat vestibular migraine are different than some of the medications that we use to treat other migraine disorders. And so beta blockers can be used, calcium channel blockers. Those aren't typically used in migraine, but can be effective in vestibular migraine. Tricyclic antidepressants, certain anti-epileptic medications are effective. And then Effexor can also be used. I think the best thing, however, is to get the patient into a headache clinic. Some patients may benefit from vestibular physical therapy to address their chronic imbalance and to reduce their functional impairment, especially the patients who can't go to a grocery store or ride in a car without getting dizzy. Oh, am I missing a slide? Oh. Last slide on vestibular migraine. So some clues to vestibular migraine. So certain features that you may see in these patients that are different than Meniere's disease patients. Patients with vestibular migraine often have a history of anxiety or depression. They have a personal or family history of migraine disorder. These are the patients who get sick in a car. They're really intolerant to motion. And so elevators, car rides cause trouble. Patients will say, I can't stare at a computer screen for too long, or if I'm in a crowd or at the grocery store, all of those visual stimuli can trigger a migraine episode, a vestibular migraine. These patients may have hearing loss, and so you cannot use hearing loss alone to say this is Meniere's disease. There's no vestibular migraine. But what's different about the hearing loss and vestibular migraine is that it's often bilateral and symmetric, as are the tinnitus and fullness if the patients do have them. And then in general, the migraine patients tend to be younger than the Meniere's disease patients. They're more likely to be female, but really in both diseases, patients are more likely to be female. Oh, okay. And so lastly, how much time do we have? We'll briefly cover some updates in hearing rehabilitation. The first is cochlear implant for single-sided deafness. This was approved by the FDA last summer, July of 2019, but this approval is only for the Meniett device. It's approved for patients over the age of 5 with single-sided deafness, and we define that as severe to profound sensorineural loss in one ear with normal to near normal hearing in the other ear. The trouble with single-sided deafness is these patients struggle with sound localization, they struggle to hear in noise, they have decreased quality of life, and they're often bothered by tinnitus in that ear. Cross and bicross hearing aids have previously been the hearing solution for patients with single-sided deafness. But some of the trouble with these devices is they don't help with sound localization, of course, because all of the sound is being routed to the better hearing ear, and these patients still struggle to hear in noise. And so to meet criteria for cochlear implantation for single-sided deafness, patients should have a pure tone average of 90 or greater decibels in that ear. The hearing loss duration should be less than 10 years. On speech testing, they should correctly repeat less than 5% of words on monosyllabic CNC word testing in quiet. And they should have at least a 1-month trial of a cross or bicross hearing device because they may find that that is sufficient to meet their hearing needs. Common etiologies for cochlear implantation for single-sided deafness include Meniere's disease, idiopathic sudden sensorineural loss, tumors, labyrinthitis, herpes zoster, and trauma. We'll kind of briefly go through a couple of these studies. This study was out of Iowa, published in the Laryngoscope this spring, published ahead of print last fall. It's the largest study to date looking at hearing outcomes in patients undergoing CI for single-sided deafness. They had 60 patients in their group with a variety of etiologies. All patients showed a significant improvement in their speech understanding in both CNC and AZ BIOS testing at 3 months. And then after that, the hearing improvement stabilized. There was no significant improvement beyond 3 months. They found that patients with idiopathic sudden sensorineural hearing loss and patients in what they called their other category, so the non-Meniere's patients, had the greatest improvements in speech understanding. They also looked at sound localization, and so patient determining from what position a sound originated, and they found that sound localization did improve over time, but it didn't reach statistical significance. And then the last thing that they looked at was tinnitus and quality of life outcomes. And so looking at social, physical, and emotional well-being outcomes, patients had a significant improvement in quality of life as they did with hearing abilities, including hearing and noise. But the patient's perception of tinnitus, while improved, wasn't statistically significant. In another recent study published this spring, the group out of South Carolina performed a systematic review and meta-analysis looking at the treatment of tinnitus with cochlear implant for single-sided deafness. And so they looked at 17 studies and over almost 250 patients. And on the tinnitus handicap inventory, as well as the VAS for loudness, patients reported a significant improvement in their tinnitus symptoms. In general, most of the patients had improvement of their tinnitus symptoms. 15% had complete resolution, 75% partial. Close to 8% didn't notice any change in their tinnitus, and only 3% reported worsening of their tinnitus after cochlear implant. And then the last topic, it's an option for single-sided deafness, but of course an option for rehabilitation of mixed and conductive hearing loss, and these are our bone conduction hearing devices. The two I'm going to highlight today are the Meniett bone bridge and the Cochlear Ossia. The bone bridge was released initially in 2018, but the device was updated or revised in 2019 to be a slimmer, lower profile device. And then Cochlear's device was released this spring. Briefly, some background on BAHA or bone anchored hearing aids, bone conduction hearing devices. They come of two varieties: percutaneous devices in which an abutment protrudes through the skin, and transcutaneous devices in which a magnet lives underneath the skin and the outer device connects via the magnet as compared to snapping on. The downside to the percutaneous devices are the potential for chronic skin infection or dermatitis and the need to keep the abutment clean. There's a number of transcutaneous devices that are available. The downside to the transcutaneous devices as compared to the percutaneous devices is that with the magnetic device, the sound signal has to be transmitted through the skin. And the reason for this is that the transducer sits on the outside of the skin and then the implant sits under the skin. And so the sound signal is attenuated, especially in the higher frequencies. And so this results in less amplification and less gain than in the abutment devices. And so these are approved for both single-sided deafness as well as mixed conductive hearing loss. But in patients with single-sided deafness, they may do better with a percutaneous device because that attenuated sound signal, of course, has to travel to the opposite cochlea, so it's further attenuated. Now, however, there are active bone conduction hearing devices. And so the difference between the active bone conduction and the passive bone conduction is where the conduction is occurring. And so with the metal bone bridge, there is an electromagnetic transducer. That's this portion of the device here, and that sits underneath the skin. And so the vibrations don't have to travel through the skin to the subcutaneous implanted device, but instead are generated underneath the skin. The downside to this device is that you have to drill a well to accommodate this electromagnetic transducer. The current iteration of this device, the transducer is only 4 millimeters in depth, but the initial was 8 millimeters and required a lot of drilling and, of course, a preoperative CT scan for placement. The latest of these devices is Cochlear's Ossia device that was released this year, and we've been using at our institution. The difference between Cochlear's device and the bone bridge is the type of electricity that's generated. And so instead of electromagnetic vibration being generated underneath the skin, it's instead a piezoelectric stimulation. And so piezoelectricity, it's not a device, it's a property of a material. And so it's a property of ceramics, it's a property of crystals. And the way that this works is that when you compress or put tension on this material, it results in a voltage. And then the opposite is also true. If you apply voltage to this material, it results in compression or tension. And that compression or tension is movement. So that's the vibration, and that's the sound that's being sent to the inner ear. Because this portion of this device is vibrating while you don't have to drill a well like the bone bridge, it's really important that the actuator is not making contact with the bone. So you do have to drill a flat surface to prevent dampening of the sound signal. So again, the advantage of the active bone conduction hearing devices is that there's no attenuation through skin. And so this allows for greater gain, especially in the high frequencies, compared to the BAHA Connect, which is the magnet BAHA. There's on average 12 dB more gain in the higher frequencies between 2 and 6 kilohertz as compared to the other device. And so this makes this a better option for patients with single-sided deafness than the BAHA Connect. And then lastly, because so much of the technology and the power is being generated underneath the skin, it allows for a smaller and lighter processor because there's no external transducer again. And then with that, the magnet does not have to be as powerful, so it can be more comfortable for our patients. And then some hearing outcomes we won't discuss, and that is it. Thank you.